Okay, so bache, this starts us with our second topic in hematology, bleeding disorders. We are done with RBC disorders. That was a huge topic, no doubt about it. The remaining three topics, bleeding disorders, blood banking, blood cancer. ये तीनों topics, they are very important. You get about 1 to 2 questions from each of these chapters in your paper. कोई भी paper हो, NEET-PG, FMGE, INI, कोई भी paper हो. Very, very important. We cannot afford to go wrong in these. So let us start with bleeding disorders. सबसे पहले बॉडी में कहीं पर भी ब्लीडिंग हो रही है, द फर्स्ट थिंग इज फॉर्मेशन ऑफ प्राइमरी हीमोस्टेटिक प्लग. सबसे पहले द बॉडी वांट्स कि ब्लीडिंग शुड स्टॉप. सो द फर्स्ट स्टेप इज फॉर्मेशन ऑफ प्राइमरी हीमोस्टेटिक प्लग विच हैज 3 स्टेप्स. 3 स्टेप हैं. दैट इज प्लेटलेट एडिशन. इट हैज 3 स्टेप्स. Platelet addition, leave 2 lines, followed by recruitment of platelets. Platelet addition, which is followed by recruitment of platelets and release of granules. Recruitment of platelets and release of granules, in turn leading to platelet aggregation. In turn leading to platelet aggregation. So primary hemostatic plug, 3 स्टेप है. Platelet addition, recruitment of platelets and release of granules, platelet aggregation. So first point, let us assume that this is the blood vessel. Blood vessel is lined by endothelial cells. Blood vessels की क्या lining है? It is lined by endothelial cells. Endothelial cells secrete von Willebrand factor. They secrete von Willebrand factor. So platelet addition is mediated by GP1B present on platelets. This is the platelet, GP1B present on platelets, binding with von Willebrand factor secreted by endothelial cells. Binding with von Willebrand factor secreted by endothelial cells. Platelet addition, which leads to recruitment of platelets and release of granules, in turn leading to platelet aggregation. Platelet aggregation मतलब platelets they bind with each other. Platelets aggregate हो रहे हैं, which is mediated by GP2B3A. Platelet aggregation which is mediated by GP2B3A. Now there are 4 diseases in primary hemostatic plug. 4 diseases है. Defect in GP1B, defect or deficiency of GP1B is called as BSS, Bernard-Sollier syndrome. Deficiency of GP1B, BSS, Bernard-Sollier syndrome. Deficiency of von Willebrand factor, von Willebrand disease. क्या inheritance है? We have written VWD in capitals now. Von Willebrand disease, autosomal dominant. We saw it in genetics also. Deficiency of GP2B3A. Deficiency of GP2B3A. That is Glanzmann's thromboasthenia. That is Glanzmann's thromboasthenia. देखो easy to remember. ABCD. B पहले आता है ना. So deficiency of GP1B is BSS, Bernard-Sollier syndrome. Deficiency of GP2B3A is Glanzmann's thromboasthenia. Both of these are autosomal recessive in nature. Both of these are autosomal recessive. Versus antibodies against GP1B. Antibodies against platelets. Which platelet receptors? Antibodies against GP1B and GP2B3A. Antibodies against them is called as ITP. It is called ITP. That is immune antibodies है ना, so the platelet count reduces. Immune thrombocytopenic. Platelet count reduces. If platelet count is low, it leads to hemorrhagic spots on skin. Immune thrombocytopenic purpura, ITP. It is which hypersensitivity? We have done this in immunity, general path. I want all of you to tell me antibody है ना. The minute you have the presence of an antibody, it is antibody mediated hypersensitivity, type 2 hypersensitivity, ITP. So there were 4 diseases associated with primary hemostatic plaque formation: Burnett-Sollier syndrome, Glanzmann's thromboasthenia, von Willebrand disease, and ITP. First class. This was primary hemostatic plaque formation. It had 3 steps. Primary hemostatic plug ने क्या किया? It controlled bleeding. It was a platelet plug. It controlled bleeding. Primary hemostatic plug progressed to secondary hemostatic plug. It progressed to secondary hemostatic plug. Secondary hemostatic plug, which it occurs by 2 pathways: an intrinsic versus extrinsic pathway. It occurs by 2 pathways: an intrinsic pathway, intrinsic versus extrinsic pathway. It occurs by 2 pathways, intrinsic and extrinsic. Extrinsic pathway starts with tissue factor. It starts with tissue factor, which in turn activates factor 7, and goes to common pathway. Which is the first step of common pathway? Conversion of factor 10 to 10A. 10 to activated form of factor 10. You very well know that coagulation factors, normally they are inactive. They are secreted by liver, normally inactive. They are activated in coagulation. 10 to 10A, activated form of factor 10, which needs 3 things. Calcium, 3 चीजें चाहिए. Calcium, phospholipids, and factor 5. It needs 3 things: calcium, phospholipids, and factor 5. 10 to 10A, activated form of factor 10, which converts prothrombin to thrombin. It converts prothrombin to thrombin, which in turn converts fibrinogen to fibrin. Which in turn converts fibrinogen to fibrin. This is secondary hemostatic plaque formation. Extrinsic plus common pathway. End product क्या है? Formation of fibrin clot. This is the end product. Body wants कि bleeding रुक जाए. It needs to form a fibrin clot. That is the end product. End में fibrin बनना है ना. So fibrinogen is coagulation factor 1. Prothrombin is coagulation factor 2. Prothrombin को coagulation factor 2 बोलते हैं. This is extrinsic plus common. Versus intrinsic pathway, which starts from 12, activates 11, 10 common में, 9, 8, and then it goes to the common pathway. 12, 11, 9, 8, 10 was in common. So you are even asked the coagulation factors involved in extrinsic and intrinsic pathway. Next point. This is a very important slide, especially FMG segment, which there are just 3 slides in this topic: primary versus secondary hemostatic plaque formation. Next, the types of bleeding, followed by the master table of bleeding disorders. These are the 3 main slides in this chapter. Next point, which is the test for extrinsic pathway? PT. Test used for extrinsic pathway, PT. That is prothrombin time. Normal prothrombin time being 12 to 16 seconds. Test for extrinsic, PT. Versus test for intrinsic pathway, PTTK or APTT. PTTK, that is partial thromboplastin time. PTTK, that is partial thromboplastin time with Qulin. Or activated partial thromboplastin time. PTT क्या है? Partial thromboplastin time. Test for intrinsic plus common pathway PTTK or APTT. Normal being 24 to 36 seconds. Normal being 24 to 36 seconds. These are the tests for extrinsic and intrinsic pathway. You need not remember the normal value, it will be given in the paper. What will be given to you as PT of a patient is 20 by 16 seconds. खुद बताओ, tell me yourself, if PT is 20 by 16, low, normal, high? High PT. If it is 16 by 14 seconds, 2 second gap is okay now, this is normal. 16 by 14 normal, 20 by 16 high PT. So this is how it will be given, same thing in PTTK also. So this was primary hemostatic plug, which had 3 steps, which progresses to secondary hemostatic plug formation, the end point of which is formation of fibrin clot. Recent NEET-PG PYQ, straightforward question. Test for evaluation of, this was the exact question, exact options. Test for evaluation of whole coagulation profile. Test for evaluation of whole coagulation profile. Whole coagulation profile is PT, PTTK, PT, PTTK, bleeding time, या TEG. They had not given the full forms. You are sitting in the paper, what will you mark? देखो बच्चे, BTCT, bleeding time, clotting time, they are obsolete tests. They are not performed now. They do not have much significant value. In today's era, we have better tests. PT is a test for extrinsic pathway, PTTK is for intrinsic. They are not for whole coagulation profile. So the answer left by default is TG, even if I do not know the full form of the same. So TG stands for thromboelastography. TG is thromboelastography. Test for evaluation of whole coagulation profile, TG, thromboelastography, which evaluates, thromboelastography evaluates both clot formation, that is formation of fibrin clot, clot formation, plus lysis of the clot, that is plus fibrinolysis. So it is evaluating the whole coagulation profile, formation of the clot as well as clot lysis, TG. So this was secondary hemostatic plug formation. Acha, tell me this, have a look at this. Which is the main regulator of coagulation profile? Main regulator, thrombin. Everything is regulated by thrombin. Main regulator of coagulation profile, thrombin. Next, let us have a look at salient features of coagulation factors. All coagulation factors are synthesized in liver. All coagulation factors, they are synthesized in liver, except, all are synthesized in liver except factor VIII. All are synthesized in liver except factor VIII. Factor VIII, it is factor VIII plus von Willebrand factor. Factor VIII, it is factor VIII plus von Willebrand factor. Von Willebrand factor is secreted by endothelial cells. You already know this. All are synthesized in liver except factor VIII. Factor VIII is factor VIII plus von Willebrand factor, which is secreted by endothelial cells. Next, coagulation factor with least half-life. Coagulation factor with least half-life, very important. Factor 7. Least half-life factor 7. कितनी है? 4 to 6 hours. 4 to 6 hours. So understand the significance of this question. You are given a question that is earliest parameter to be affected. Suppose your question is earliest parameter to be affected in early liver disease. Earliest parameter to be affected in early liver disease is increased PT, increased PTTK, increased bilirubin या reduced albumin. See, all four things will happen in liver disease. PT increases, PTTK increases, bilirubin increases, albumin reduces. All four things will happen. But which is the first parameter to be affected? Which coagulation factor has the least half-life? Factor 7, 4 to 6 hours. Factor 7 will become abnormal the earliest. Where is factor 7 used? Extrinsic pathway. Where is it used? Extrinsic pathway. So, test for evaluation of extrinsic pathway, PT. So, which is the earliest parameter to be affected? Elevated levels of PT. PT increases. Next point. So, least half-life, hence this statement is important. Least half-life, factor 7. Longest half-life. Next point. Longest half-life, factor 13. Again, extremely important. Longest half-life, factor 13. Factor 13, which it is also called as fibrin stabilizing factor. Factor 13, it is also called as fibrin stabilizing factor. So, खुद सोचो, think of it yourself. If fibrin stabilizing factor is deficient, है, so fibrin clot is not stable, fibrin clot stable ही नहीं है, leading to delayed bleeding. So, clinically, deficiency of factor 13 causes delayed bleeding. So, girls, बच्चे, when was the first time you bled? I want all of you to think back and commit to this answer. अपने मन में बताना please. When was the first time you bled? नहीं, I don't want to hear 11, 12 years. नहीं बच्चे, नहीं. Guys, tell me, when was the first time you bled? Childhood तो ठीक है, but कब? पहली बार हमारा लाइफ में कब कटा था? Umbilical cord, the minute we were born. So, all of us bled when the umbilical cord was cut. So, the classical clinical history of factor 13 deficiency is delayed bleeding from umbilical cord stump. Delayed bleeding from umbilical cord stump. Factor 13 deficiency. So, longest half-life, factor 13. कितनी half-life है? 11 to 14 days. Half-life of least half-life was factor 7. कितनी? 4 to 6 hours. Factor 13, 11 to 14 days, fibrin stabilizing factor. So, the minute you are given a history of a child with delayed bleeding from umbilical cord stump, answer factor 13 deficiency. Next one, test used for factor 13 deficiency. We use urea clot lysis test. Test used urea clot lysis test, meaning we add urea to clot. If fibrin clot is stable, अगर fibrin clot stable है, तो lysis will not occur. If lysis occurs, that means fibrin stabilizing factor deficient है. So, test for fibrin stabilizing factor, urea clot lysis test. हमने clot में urea डाला and we are looking at lysis. Urea clot lysis test, factor 13. Next, vitamin K dependent factors. I am sure you already know this again. Vitamin K dependent factors. They are factors 2, 7, 9, 10. Vitamin K dependent 2, 7, 9, 10. Along with factors 2, 7, 9, 10. और क्या vitamin K dependent है? Protein C and protein S. Vitamin K dependent 2, 7, 9, 10. Which had the least half-life? Factor 7. अभी देखा ना. तो which will be the first parameter to become abnormal in vitamin K deficiency? PT, Factor 7 deficiency causes increased PT, extrinsic pathway increased PT. Fair enough. Next, anti-hemophilic factors. Next point, anti-hemophilic factors, ABC. मतलब हीमोफीलिया किसकी डेफिशिएंसी से होता है? It occurs due to deficiency of coagulation factors 8, 9, 11. तो anti-hemophilic factors ABC मतलब 8, 9, 11. Anti-hemophilic factor B, that is coagulation factor 9, is also called as Christmas factor. Anti-hemophilic factor B, that is coagulation factor 9. Coagulation factor 9 is also called Christmas factor. Which was the first coagulation factor in common pathway? Factor 10. So I can safely say Stewart-Power factor. I can safely say it is the most powerful factor. Stewart-Power factor, factor 10. Factor 10. All of us have seen Stuart Little. It was a nice, cute movie. So Stewart-Power factor, factor 10. First class. This was with respect to primary and secondary hemostatic plug formation along with the salient features of coagulation factors. अच्छा, though we have covered this in blood banking, but एक बार फिर से मुझे बता दो, anticoagulant of choice, anticoagulant of choice for both ESR and coagulation profile. दोनों के लिए anticoagulant of choice for ESR and coagulation profile is sodium citrate. Anticoagulant of choice is sodium citrate. Important है. So let me rephrase. Sodium citrate is the anticoagulant of choice for both ESR and coagulation profile. ESR वो Wintrobes या Westergreen tube में होता है ना, it's a straight tube. When we are using it for ESR, the ratio is 1:4 diluted है. That means 1 unit anticoagulant, 4 units blood. Versus when we use it for coagulation profile, ratio is 1:9. 1 unit anticoagulant, 9 units blood. Next point, for doing coagulation profile मतलब PT के चेक करने के लिए, for coagulation profile, what is the sample used? The sample is PPP, platelet poor plasma. The sample is PPP, that is platelet poor plasma. Sample used PPP. Why? We are doing coagulation profile. I want to check for deficiency of coagulation factors 7, 8, 9, 11, not deficiency of platelets. So we add platelets, that is the test used or the sample used PPP, platelet poor plasma. Next point, ठीक है, मान लिया, agreed. So this gets us to our next and a very important topic, that is bleeding. Before we make the master table of bleeding, whenever a patient comes to us, मेरी first priority है to check whether this bleeding is due to platelet deficiency. मुझे सबसे पहले चेक करना है whether this bleeding is thrombocytopenia. डेंगू में होता है ना, platelet count reduces leading to hemorrhagic spots on skin. Whether this bleeding is due to platelet deficiency or due to coagulation factor deficiency. I want to check this, whether it is due to platelet or coagulation factor deficiency. Bleeding due to platelet deficiency is seen in, क्यों होगी? It is seen in dengue infection. Platelet count is low. Destruction of platelets due to ITP, immune thrombocytopenia purpura. Antibody against platelets leading to thrombocytopenia, leading to purpura, hemorrhagic spots on skin. Platelets कहाँ destroy होते हैं? Spleen में. hypersplenism. It can be due to hypersplenism. Clinically leading to hemorrhagic spots on skin. Clinically leading to petechiae and purpura. अब petechiae and purpura किस में नजर आएगा? हम लड़कों में या गर्ल्स में? Girls are the fair sex now. We are dark skinned. So more commonly seen in females. More commonly seen in females. And family history is usually absent. मच्छर के काटने से हुआ है ना, we'll not consider कि अच्छा मच्छर ने लड़की को भी काटा, पापा को भी काटा, नहीं. Family history is absent. This is platelet deficiency. Versus coagulation factor deficiency bleeding. The classical example of which is hemophilias. Hemophilia ABC, which occur due to deficiency of coagulation factors 8, 9, 11. You know that. Hemophilia. Hemophilia हम कैसे लिखते हैं? XH. So it is X-linked recessive. Hence family history is present. X-linked recessive है तो male predominant है. More commonly seen in males. We know this from genetics also. Male is XY now. It is seen in males. Clinically, अब bleeding कहाँ हो रही है? Is it small hemorrhages on skin, petechiae purpura? No. There is bleeding in joint cavity. Clinically, it is associated with hemarthrosis, bleeding in joint cavity, hemarthrosis and deep thigh hematomas. Clinically it is associated with hemarthrosis and deep thigh hematomas. These are the two main types of bleeding. जब भी कोई patient bleeding के साथ आया, we have to check whether it is a platelet deficiency bleeding or a coagulation factor deficiency. So a very, very important image. Have a look at this image. Have a look at this. The minute I see this case, देखकर ही पता चल रहा है कि he is a male having deep joint bleed, hemarthrosis. It can be a case of deep thigh hematoma also, making the diagnosis as hemophilia. Making the diagnosis as hemophilia. This is what coagulation factor deficiency bleeding looks like. Hemophilia, is it a good disease to have or a bad disease? Which it's not a good disease. Why? Child is not able, see, when we are children, we play, we fall and we heal. Hemophilia का बच्चा, he is playing football. उसने सिर्फ तेज kick मारी, he did not even fall, nothing. There was minor trauma to the knee joint, तो bleeding शुरू हो गई, वो control ही नहीं हुई. Repeated bleedings damages the joint and causes pain also. It's not a good disease. It's not a good disease to have. So this starts us with our master table of bleeding disorders. Which is this starts us with master table of bleeding disorders. हम लोग table बना रहे हैं. Please write it like this only. PT, PTTK, platelet count and diseases associated. PT, PTK, platelet count and the diseases associated. Starting with the first one. PT is increased, PTTK is normal, platelet count is normal. Answer. Isolated elevation of PT. Isolated elevation of PT. Only PT is increasing. Means which coagulation factor is involved in extrinsic pathway? Factor 7. Factor 7 की क्या खासियत थी? It had the least half-life. Remember? So it is seen in early liver disease. In early liver disease, which is the first coagulation factor to be affected? Factor 7, leading to increased PT. Early vitamin K deficiency, early liver disease, early vitamin K deficiency. Early vitamin K deficiency. Vitamin K dependent factors are 2, 7, 9, 10. First to be affected will be factor 7, leading to increased PT. Next is PT is normal, PTTK is increased. Isolated elevation of PTTK, platelet count is normal. PTTK, which are the coagulation factors involved in intrinsic pathway? 12, 11, 10 was in common, 9, 8. 12, 11, 9, 8. Deficiency of coagulation factors 8, 9, 11. This is hemophilia ABC. These are the hemophilias. Hemophilias ABC. Other than hemophilia, that is deficiency of coagulation factors 8, 9, 11, isolated elevation of PTTK is also seen in von Willebrand disease and because of heparin. You will be seeing this in pharma. Warfarin deficiency, warfarin therapy causes isolated elevation of PT. Early warfarin, this is pharma bache, early warfarin. So, what is tested in cases of early warfarin therapy? PT, prothrombin time, versus heparin, which causes isolated elevation of PTTK. Next, both continuing the same table, PT, PTTK, platelet count, diseases associated. Let us continue the same table. Next is both PT and PTK are increased. Both PT and PTK are increased, platelet count is normal. Answer. In my face-to-face classes, I usually hear there is a defect in common pathway. Fair enough. If there is a problem in common pathway, like factor 10 deficiency, afibrinogenemia, fibrinogen is absent, afibrinogenemia, dysfibrinogenemia, that is common pathway defect. Fair enough. But these are very rare. I will not even write them. Tell me the common causes of elevation of both PT and PTK. Where are all coagulation factors synthesized? कहाँ बनते हैं? Liver. Early liver deficiency में सबसे पहले increase हुआ PT, because least half life was factor 7. लेकिन जैसे जैसे chronic liver disease होगी, gradually other coagulation factors will also reduce, leading to increased both PT PTK. Chronic liver disease. Late vitamin K deficiency. Late vitamin K deficiency. It causes elevation of both PT and PTK. Next is PT and PTK are increased. PT and PTK are increased, platelet count is reduced. How is the patient? Patient life में खुश है या there is total havoc in coagulation profile? There is total havoc. PT PTK increase है, platelet count is low. Diagnosis DIC, disseminated intravascular coagulation, DIC. And lastly, PT and PTK are normal. PT and PTK are normal. Platelet count is reduced. Matlab, this is a case of thrombocytopenia. This is a case of thrombocytopenia. Only the platelet count is low. It is a case of thrombocytopenia. We will see this just in 1 minute, but just have a look at the table once again. Purely understanding based. Isolated elevation of PT, तो factor 7 abnormal था. Early liver disease, early vitamin K deficiency. Isolated elevation of PTTK, hemophilias, von Willebrand disease and heparin. Both PT PTK are increased. Chronic liver disease, late vitamin K deficiency. PT PTK high, platelet count low, DIC. Lastly, just the platelet count is low, thrombocytopenia. What are the causes of thrombocytopenia? So, this gets us to thrombocytopenia. Let us see the causes here only. We just saw PT normal, platelet count is low. Why is the platelet count low? Because of decreased production of platelets. There is reduced production of platelets in the bone marrow. Where are platelets produced? In bone marrow. Due to aplastic anemia. aplastic anemia में तो सारे cells ही बंद है ना bone marrow में. There is bone marrow failure. aplastic anemia. Nutritional deficiencies, that is folic acid and B12 deficiency. Please note, इसमें मैंने iron deficiency anemia नहीं लिखा. In iron deficiency anemia, platelet count is high. Folic acid and B12 deficiency, everything is low platelet count. Next, it can be because of drugs and alcohol. Drugs like thiazides, diuretics and alcohol. Reduced production of platelets. Next, it can be because of increased destruction of platelets. या तो बने कम इसलिए प्लेटलेट काउंट लो था, या डिस्ट्रक्शन ज़्यादा हो गई. Increased destruction of platelets. Why? Because of ITP, immune thrombocytopenic purpura, antibody against platelets था. DIC, disseminated, पूरी बॉडी में इंट्रावैस्कुलर ब्लड वेसल्स में कोगुलेशन हो रहा है. What is a blood clot? It is an aggregate of RBC, fibrin and platelet. Blood clot बनाना तो उसमें platelets फंस गए, so platelet count is low. DIC, and lastly it can be because of SLE or B cell blood cancers or B cell neoplasms, increased destruction of platelets. And the last cause of thrombocytopenia being, where is destruction of platelets taking place? In spleen, that is hypersplenism. This is thrombocytopenia. Platelet count was reduced, either because of reduced production, increased destruction or hyperactivity of spleen, hypersplenism. First class. So बच्चे, this takes care of our master table of bleeding disorders. PT के platelet count and diseases associated. This gets us to our last two miscellaneous topics in the chapter bleeding disorders. We'll first have a look at ITP, followed by DIC and von Willebrand disease, and we wrap up the chapter. So let us start with our first topic, that is ITP, immune thrombocytopenic purpura. ITP, you already know, immune है ना, so it is associated with presence of antibodies against platelets. Antibodies against which receptor of platelets? Antibody against GP1B9 and GP2B3A present on platelets. So it is which hypersensitivity reaction? Antibody mediated hypersensitivity type 2. You know this. Antibody थी ना, so it is antibody mediated hypersensitivity. ITP. ठीक है, मान लिया. Point is, ITP is of two types. Let us make a flowchart of the same. ITP, बच्चे, it is of two types. Acute versus chronic ITP. Acute versus chronic ITP. If you just know that acute ITP is seen in children, which is more severe? Acute. Acute conditions are usually more severe. No? It is seen in children. बच्चों में disease कैसे होती है? Usually after respiratory tract infections. It is seen in children. Usually after respiratory tract infections. seen in children usually after respiratory tract infections. Acute ITP. This is more severe. This is more severe. That is, in this, platelet count is less than 20,000 per microliter. It is less than 20,000 per microliter. You know that spontaneous bleeding occurs at platelet count less than 20,000. Kahan? It can bleed in brain also, na? Leading to sudden death. So, acute ITP is a medical emergency. It is a medical emergency. It can be associated with sudden intracranial bleed. But acute tha. So, it is self-resolving. It is self-resolving. It becomes okay within 2 to 6 weeks. Within 2 to 6 weeks. Acute ITP versus chronic ITP. So, you knew all this just by a point that acute ITP is seen in children. Versus chronic ITP, which is seen in adults. If you know this, you know everything. Chronic hai, long term hai. It is less severe. It is less severe. Platelet count is 50 to 80,000 per microliter. So, spontaneous bleeding is not seen. So, spontaneous bleeding is absent. Spontaneous bleeding is absent. It is not a medical emergency. It is chronic in nature. Long term hai, chronic hai. It persists for months to years. It persists for months to years. This is acute versus chronic ITP. All you had to know was acute ITP. Acute is seen in children, chronic adults. Acute versus chronic ITP. Much more important than this table is the therapy for ITP. So, this starts us with therapy. The first line therapy, there is presence of antibody against platelets. So, first line में हम क्या करेंगे? We'll give steroids. First line therapy of ITP being steroids. Next, there is antibody against platelets in blood. I want to remove this antibody from the blood. What is that called as? Plasmapheresis. और क्या कर सकते हैं? We can perform plasmapheresis. Removal of antibody from the blood. Or next first line therapy is IV immunoglobulins. Intravenous immunoglobulins can be given. Intravenous immunoglobulin, it binds to antibody against platelets. Body mein there is antibody against platelets. If I give IV immunoglobulin, it binds to this antibody against platelets. So, now it cannot bind to platelet. First line therapy. Steroids, removal of antibody from blood. Plasmapheresis, IV immunoglobulins. Second line therapy. If the patient is not responding to this, second line therapy being splenectomy. Where is destruction of platelets taking place? Spleen, splenectomy. And lastly, third line. Third line therapy is to be given when both first and second line do not respond. You have performed splenectomy also. Both first and second line do not respond. In that case, we give platelet analogs. In that case, we give platelet analogs. This was our first miscellaneous topic, that is ITP. Immune thrombocytopenic purpura. ITP. Next, which is this gets us to our next and again an important, small but an important topic, von Willebrand disease. This gets us to von Willebrand disease. छोटा सा 2-minute topic है, but it is important. Von Willebrand disease. Inheritance, we have written it in capitals now. Autosomal dominant, first point. But von Willebrand disease. Let us make the master table. It is not asked. Previous, I think 6-7 years, it has never been asked. But let us make the master table of the same. Von Willebrand disease, which it is of 3 types. Type 1, type 2 and type 3. Von Willebrand disease, it is of 3 types, type 1, 2, 3. Most common, type 1. Most common कौन सा है? Type 1. ठीक है, मान लिया. Type 1 and 2 are autosomal dominant. Type 3 is autosomal recessive. Type 3 autosomal recessive. So if somebody asks you the inheritance of von Willebrand disease, autosomal dominant. Type 1 and 3 are quantitative defects. Type 1 and 3, they are quantitative. They are quantitative defect. Versus type 2, which is a qualitative defect. Versus type 2, which is qualitative defect. So you tell me which will be more severe, type 1 or type 3? Type 3 is autosomal recessive now. Disease will occur when both alleles are abnormal. दोनों एलील खराब होंगे तभी डिजीज होगी. दैट इज ऑटोसोमल रिसेसिव. सो विच इज मोर सीवियर? टाइप 3. टाइप 3 मोर सीवियर. इट इज मोर सीवियर. ठीक है, फेयर इनफ. दिस वाज द मास्टर टेबल. दिस वाज द मास्टर टेबल ऑफ वॉन विलेब्रेंड डिजीज. मान लिया. पॉइंट टू बी नोटेड हियर इज टेस्ट फॉर वॉन विलेब्रेंड डिजीज. टेस्ट यूज्ड, very important. First is isolated elevation of PTTK. We saw this in the master table also. When PTTK is increased, it is mainly because of hemophilias or von Willebrand disease. Next, put a star. Test used, RIPA test. Test for von Willebrand disease, RIPA. That is ristocetin induced. That is ristocetin induced platelet aggregation test. RIPA, ristocetin induced platelet aggregation test. It is a type of platelet aggregation test. It is a type of platelet aggregation test. What does it mean? Platelet aggregation test. इसमें we put ADP, collagen and ristocetin in platelets and look for disease. हमने 3 वाइल ली, एक में ADP डाला, एक में collagen, तीसरे में ristocetin, and we look for disease. Normally platelets, they should aggregate with all 3. If I am normal, at least with respect to platelets, I am normal. So when you take my 3 samples, put ADP, collagen, ristocetin, everything should aggregate. It is a platelet aggregation test. Aggregation should occur. Suppose with ADP aggregation is normal. With collagen it is normal. But with ristocetin aggregation is reduced or absent. What is the name of the disease? Von Willebrand disease. Von Willebrand disease. That is in von Willebrand disease, ristocetin induced platelet aggregation is absent. Other than von Willebrand disease, it is also seen in Bernard-Sollier syndrome. Other than von Willebrand disease, it is also in Bernard-Sollier syndrome. Versus opposite, aggregation with ADP is reduced, collagen is reduced, with ristocetin is normal. Opposite, this is a case of Glanzmann's thromboasthenia. This is a case of Glanzmann's thromboasthenia. Glanzmann's thromboasthenia. This is platelet aggregation test. This is platelet aggregation test. First class. We are exposing the platelets to ADP. हमने platelets में क्या क्या डाला? ADP, collagen and ristocetin, and we are looking at diseases. Platelet aggregation test. So instead of writing like this, suppose examiner gives you these flowchart: ADP, collagen, and ristocetin. He just told you that black is normal. Black is normal. Normal will always be given, and red is patient. Red is patient. This is what you are able to see. Diagnosis. I need not even tell you x-axis kya hai, y-axis kya hai, does not matter. Ristocetin induced platelet aggregation is absent. Diagnosis: von Willebrand disease. Diagnosis: von Willebrand disease. Very important. This is platelet aggregation test. Von Willebrand disease. First class. So we are done with ITP, immune thrombocytopenic purpura, ITP, von Willebrand disease, and lastly, which is, this gets us to our absolute last topic in bleeding disorders, that is DIC. This gets us to DIC. Disseminated throughout the body, there is intravascular coagulation. Disseminated intravascular coagulation, DIC, coagulation. So first point, starting with DIC, the name tells you everything. Blood vessels में coagulation हो रही है throughout the body, disseminated है. So what happens is, there is thrombus formation in blood vessels. So it is a thrombotic disorder. There is thrombus formation. What is thrombus? It is an aggregate of RBC, platelet and fibrin clot. Fibrin clot है with RBC and platelet. तो platelet count is reducing. Thrombus बन रहे हैं तो clotting factors are also reducing. Clotting factors कम हो गए, platelet कम हो गए. Remember PT increased, platelet count is low. Clotting factors reduce. Let me write it for you. Clotting factors reduce, platelets reduce. Because clotting factors are reducing, PT and PTTK increase. PT increases, PTTK increases. So it is also associated with bleeding. Hence, I can safely say DIC, it is a thrombohemorrhagic disorder. Blood vessels में thrombus बन रहे हैं, gums में bleeding हो रही है. Platelet count is reducing, gums, nose, other sides, skin, bleeding हो रही है. It is a thrombohemorrhagic disorder. Why is it occurring? Causes of DIC. It is due to infections. It occurs due to infections. कोई भी infection है, bacterial, fungal, viral, any infection. कौन से bacterial infection? Staph aureus, streptococcus, meningococci, gonococci, gram-negative bacteria, fungal, that is histoplasmosis. कौन से फंगस के कारण? Histoplasmosis, aspergillosis, fungal. It can also be due to mycoplasma. So causes of DIC. The first main cause of DIC, it occurs because of infections. Viral, herpes, rubella, so on. Does not matter. Infections. Next, it can be because of trauma or tissue injury. It can be because of trauma and tissue injury. Tissue injury releases procoagulant factors. It releases tissue factor, which causes clotting. Trauma and tissue injury, either because of burns, fat embolism, road traffic accident in turn leading to fat embolism, rhabdomyolysis. So all this is due to road traffic accident, fat embolism, rhabdomyolysis, extensive burns, gunshot injury. So DIC, it occurs because of infections, trauma and tissue injury. Next, it is also occurring because of obs-gynae complications. You will be doing it in detail in obs-gynae. Occurs due to obs-gynae complications. Which are the obs-gynae complications? That is abruptio placentae. You will be studying about all this in obs-gynae. They are very particular about these along with DIC. Abruptio placentae, amniotic fluid embolism, amniotic fluid embolism, septic abortions. अगर abortion hospital में नहीं कराया for whatever reason, किसी quack से करवाया, septic abortion, or dead fetus syndrome. The child died in the womb of the mother and उसको जल्दी नहीं निकाला बाहर. It persisted for a longer time. Dead fetus syndrome, which can progress to DIC. Obs-gynae complications. And lastly, it is also associated with malignancies. कौन से cancers के साथ देखा गया है? That is carcinoma stomach, lung cancer, and acute myeloid leukemia. कौन सा acute myeloid leukemia? AML-M3. Acute promyelocytic leukemia, we will do it in blood cancer. So DIC, disseminated, पूरी बॉडी में ब्लड वेसल्स में कोगुलेशन हो रही थी. डिससेमिनेटेड इंट्रावास्कुलर कोगुलेशन हो रही थी तो थ्रोम्बो. कोगुलेशन के कारण क्लॉटिंग फैक्टर्स वर रिड्यूसिंग, प्लेटलेट्स वर रिड्यूसिंग, लीडिंग टू ब्लीडिंग. थ्रोम्बो हेमरेजिक डिसऑर्डर, बोथ थ्रोम्बस फॉर्मेशन एज वेल एज हेमरेज वाज टेकिंग प्लेस. पीडीपीटी के हाई, प्लेटलेट काउंट लो. कॉजेस infections, bacterial, viral, fungal, histoplasma, infections. Trauma, either because of road traffic accident, fat embolism, extensive burns, gunshot injury, trauma. Obstetric complications, obs-gynae, abruptio placentae, dead fetus syndrome, septic abortions, or malignancies. These are the causes of DIC. As lab diagnosis, what is asked from you is diagnosis. In lab diagnosis, we did this in RBC disorders also. Which is the characteristic RBC morphology seen in DIC? It shows the presence of fragmented RBCs or schistocytes. It shows fragmented RBCs or schistocytes, DIC. Next, we have already seen PTK high, platelet count low. You already knew this. There are two questions which are asked. Most sensitive test for DIC, and most specific test. बच्चे, most sensitive test for DIC is increased FDPs, increased fibrin degradation products. DIC में fibrin clot is forming. As a natural process, fibrin clots get degraded, leading to formation of FDP. Increased fibrin degradation products. Increased fibrin degradation products is the most sensitive test, whereas most specific being D-dimers increase. Most sensitive elevated FTP, most specific D-dimers increase. Lastly, it was about 2017-18 NEET-PG question. What happens to fibrinogen? Fibrinogen is getting converted to fibrin. End result is fibrin clot formation now. So serum fibrinogen reduces. Serum fibrinogen reduces. First class. Absolutely and absolutely first class. So this takes care of our second, comparatively smaller than RBC disorders, but a very important topic, bleeding disorders. We had a look at primary and secondary hemostatic plug formation. क्या पढ़ा है? Primary and secondary hemostatic plug formation, followed by classification of bleeding into platelet deficiency versus coagulation factor deficiency, the master table of bleeding disorders, ITP, immune thrombocytopenic purpura, ITP, von Willebrand disease, and DIC, first class bache, first class. So this finishes bleeding disorder.